Hello, and thank you to everyone for joining me today for another Leadership Rounds discussion. I'm Rod Hochman, the CEO of Providence and the board chair of the American Hospital Association. This month, we're covering the topic of health equity that obviously has been on everyone's mind, but is one of those things that I would put on the urgent list for all of us. We know that there's an immediate health crisis facing communities of color, and it's been disproportionately affected by COVID-19. This has exacerbated existing racial disparities in care, and in a lot of ways has shown such a bright light on how wide those inequities are. We've made some progress, I can say, but the pandemic has shown us that we've got a long way to go, and everyone has a chance to live a healthiest life as possible. I think we've got one of the nation's experts with us today, and she's going to really help us enlighten all of us on this. And I think some of you may know Dr. Consuelo Wilkins. Dr. Wilkins is the Vice President of Health Equity at Vanderbilt University Medical Center and is also an Associate Dean for Health Equity at the Vanderbilt School of Medicine. For those of you that don't know, Vanderbilt University in Nashville is one of the largest academic medical centers in the Southeast. It manages about 2 million patient visits a year, and they're a primary resource for specialty and primary care for hundreds of adult and pediatric specialties. Through the Vanderbilt Health Affiliated Network, they've worked with over 60 hospitals, 5,000 clinicians across Tennessee, and 5 neighboring states to share the best practices and to bring value-driven, cost-effective healthcare to the Mid-South. Dr. Wilkins is widely recognized for pioneering methods of stakeholder engagement that involve community members and patients in all stages of biomedical and health research. She's the principal investigator of 2 NIH-funded centers. One focuses on decreasing disparities among African Americans and Latinos using precision medicine. The second is a national center dedicated to enhancing recruitment and retention in clinical trials. Dr. Wilkins serves on numerous national committees and boards, has been an invited speaker all around the country, and has been a mentor to many junior faculty and health profession students. So you can see how lucky we are to have her with us today. I'm looking forward to hearing her insights on how the pandemic has affected existing health equity efforts. Most importantly and most relevant to the day-to-day is how do we coordinate vaccine distribution to reach all communities? So Dr. Wilkins, AHA, welcome to you to bring you with us and to our audience. And thank you for joining us for leadership discussion.
It's my pleasure to be here. Thanks so much for having me.
So I'm going to jump right in. So along with your colleagues at Vanderbilt, you've been doing some great work there, and I've had a chance to review some of your papers. But employing a systems approach to COVID-19 health inequities, can you tell us a little bit about that work and about the interactive dashboard that you're using?
Yes, so early on during this pandemic, our hospital leadership recognized that disparities were wide-ranging and that we needed to do something about it. So I got the call to join the COVID Command Center and really become embedded in the operations for the institution. And I think that was really an important decision early on to make sure that health equity wasn't a silo that was outside of the command center. So I was there at the table when decisions are being made about, testing, resourcing, and communications, which was really pivotal for us to begin to think about how to embed health equity there. Of course, I didn't do it alone. I brought together a team with different disciplines and expertise in effective communications and public health, clinical trials, telehealth, all of those things that we really needed to begin to think more intentionally about how we would really identify these inequities, as well as put in some strategies to alleviate them, to really address them. So, part of what we needed to do first was to take a look at the data. And I'm sure you knew this early on as well. We heard it from the CDC. A lot of data was missing. We did not know how many people from different racial and ethnic groups actually were being impacted. We knew the data that we did have was bad, but we didn't have a full picture of that information. So the dashboards that we created were really to disaggregate the data by race, ethnicity, and primary language. And to make sure we're capturing that when we're doing the testing and hospitalizing people, we don't know what we're dealing with if we don't have adequate data. So that was first and foremost. So in our dashboards, we are looking at the race, ethnicity, primary language of people who are diagnosed with COVID-19, who are hospitalized, and unfortunately those who die. But we also had other aspects of our dashboard that relate to clinical trials. So early on during this pandemic, there are no effective treatments. We have to make sure that people actually have access to clinical trials. And also indirectly, due to the pandemic, we need telehealth. And we knew that we're likely to see reduced adoption of telehealth in some of these communities. And so our dashboards are really about disaggregating the data so we can take a closer look. And, unfortunately, we found something that many people weren't tracking very well early on, and that's some of our biggest inequities were among people who spoke languages other than English.
Wow.
And a lot of people weren't actually capturing that information. So I'm really glad that we're able to put together these dashboards that are continuously updated and really take a look and present them in the command center so we can think together about how to address them.
So as you've done that with the dashboards, any insights into what the data is showing you so far? Any, you mentioned the thing on language, which I think was an aha moment when I read through that. Others that you'd say are big ahas that you're seeing?
Well, I think, we have to take our data as a medical center, as a hospital, in the context of the populations that we're serving, as well as the broader population. So part of our dashboard is a variance from the populations that we're typically seeing. So when we looked at race, ethnicity of people that we typically see, again, we're in Nashville. There are many hospital systems, healthcare systems. There's, a minority serving institution, Meharry here, that has a much more diverse population than we have. So we want to look at what our baseline is, but also the population. And we still saw, though, that we were seeing many more minorities than we typically saw within our health system, which is good in many ways, because we want to make sure that during this pandemic, our services aren't just available to people who are more resourced or who are already part of our health system. But it's certainly unfortunate because it's a sign of this, the disparities that we've seen throughout the pandemic.
Do you think, before we get to our next topic, do you think, establishing this dashboard and data inputs, I imagine that beyond COVID, once we get outside of COVID, that this is going to be incredibly helpful in looking at other areas in cancer care, maternal and fetal medicine and whatnot. So I imagine that this will give you a good framework to kind of dig in on some of those other areas that we've seen a lot of inequities that we've been staring at for a long time.
Rod, you're exactly right. And certainly as the AHA has been pushing for a more systematic approach to health inequities and collecting data and using it to identify disparities and come up with interventions, quality improvement projects to make sure that we are addressing those. I mean, that's part of your framework. And so I definitely see this as a nice window to things that, okay, this is going to be easier for me moving forward when I come to teams to say, we've got to disaggregate all the data for, for cancer care, for pneumonia, for, heart attacks. Everything has to be disaggregated so that we can look closely at where we do see these inequities, and then we can come up with the same approach to, let's use a health equity lens to address these problems.
Because then, as you're putting that all together, the other, thing that we've noticed, I think, during the pandemic is the lack of sometimes of diversity, enough diversity in the database that we're dealing with. And, particularly where I live out west, do we have native populations in the database? And, it's amazing how sparsely represented. And then, the point that you brought up is we're not collecting the right information to really understand what's there.
Right. And so, another aspect of our dashboards are information related to social determinants of health. So
Right.
we specifically pulled in zip codes. Now, that's a crude assessment of social determinants of health. We're looking at community level issues where we know there's, more crowding in housing, more people are likely to have jobs as frontline workers. But we have that at times when we don't have that individual level data. So in our dashboards, we looked at zip codes. So, one of the first calls that I made to our state and county health departments was, okay, we see that these populations of people who speak languages other than English are more likely to have COVID, and they live in these 2 zip codes. And, that helps with the targeting at the public health level, but also staffing in our walk-in clinics and making sure that we have individuals who are bilingual, multilingual, other resources available in our health system to serve those populations. And importantly, though, reaching out to the community organizations in those areas.
Absolutely, which brings us perfectly to kind of the next topic that's on everyone's mind. And, this pandemic now a year old and now longer, now the next phase is vaccination. And my frustration, my background's in immunology, rheumatology. We need to be talking about vaccination 7 months ago, but here we are, right? And you focused your career on developing ways to improve trust between community members and providers. Tell us a little bit about how you're tackling the vaccine rollout, and have you identified vaccine hesitancy within communities that you serve? And then what steps are you taking, and what for everyone that's listening to this, how do you build trust and increase understanding, particularly in at-risk communities?
Well, certainly, this pandemic has tried trust in many ways with communities, and I think our challenges around effectively communicating about this novel virus, and where testing resources are, and how people access treatments is certainly spilling over into the vaccine rollout. So, as we're trying to make sure that there is equity in the vaccinations in the rollout, there are many things within the systems that make that really challenging to do. We certainly have seen lack of confidence in the vaccine. I was cautioned by one of my community partners recently that we should not be using vaccine hesitancy, that we should be saying vaccine readiness, because we need to make sure that we're not framing it in negative terms towards people who really need more information, haven't found this process to be transparent or trustworthy. And so what are we doing to really reflect that in our messaging, and how are we actually increasing their confidence and readiness to do that?
I kind of use the word patience, right?
Yeah.
Because, probably at Vanderbilt, just like in all of our health systems, a lot of folks have said a lot of your caregivers of color are not wanting the vaccine. I said, well, can we take a breath and be a little bit patient and kind of, so I think that's really what you're advocating, that it's not necessarily an all or nothing phenomena as this rolls out. So I think that's a great catch. And I think, in terms of what you're saying.
Yeah, you're exactly right. What we're hearing from the community is, like, slow down. This is happening really fast. We have questions. We need more information. And I think the biggest mistake that we can make is to actually invite people to be vaccinated or offer it, and then if they're not ready, to never look back. I think we have to to pause and make time and room for people to ask questions and to feel like they have enough information to make their decisions. And so that's been a big piece of what we're trying to do, which, at a cross section doesn't look so good, because if people are taking a look at all the data, they're like, well, nobody's doing really great in vaccinating underserved populations. But it's not because we aren't trying. We just have to make sure that we are providing that space. Certainly, there have been challenges with access and making sure that we're not relying completely on electronic tools and those sorts of things. And so, what we've been doing is really twofold, I would say. I've been advocating, as well as others, to make sure that community providers have access to the vaccine so that they can actually provide them in their community health centers and other settings. We should not expect that people who've never come to hospitals to be forming the lines around the block to do so. And we need to support community health centers in doing that work. But we also need to support the messaging. So we've been working with community partners, churches, to deliver the messaging. So they convene the groups, and we bring the content from the vaccine development, from the scientific expertise, to what are the side effects, and we really spend some time, though, debunking some of these myths. So a lot of the information people are getting are just things that are not true, and they need to hear it from health professionals, that this isn't true, that, it's not a tracking device, that people aren't dying from the vaccine, and they need to be able to ask those questions and believe and find us trustworthy enough to deliver that message.
Because I think your message about trusted community partners is really, really important, and the types of organizations, and those are ones that may not be as familiar to a lot of hospitals. And, we had one group in the Northwest in Seattle that are doing the pop-up vaccination centers. But the first thing they did was we have an Ethiopian community in Seattle, but they went and found those community leaders to help run the clinic, and not just a bunch of folks coming somewhere out of the medical center and everything else. But what other ideas or suggestions do you have for our audience on how to build trust in those communities, and which are the partners that they should be looking for, and how should they go about it?
Trust isn't built overnight, and people won't find us trustworthy overnight. So you really have to rely on these trusted community organizations, trusted community leaders, to partner with them at a time like this. And so I think your points are exactly that. Bringing in individuals who are already trusted by the community to be a part of the team to help with the messaging is important. Every community is different, so you have to find out, where do people go for resources? Where do they seek care, resources, just for daily living? That can be community health centers, other community centers, but where also do they feel they belong? Some of those are going to be faith-based organizations. Others are going to be, community resources, like for, many new American and immigrant communities have other organizations that make them feel welcome and belonging. So you've got to find those places and partner with those people.
Because I think that's a message for us even beyond COVID, right? So as we start to tackle these other issues, we really have to have this partnership with our community groups, and as we go, because the other thing are all of these sobering disparities that we see in health outcomes and health equity, and it doesn't stop at COVID. And your thoughts on where should we dive in? If we're going to start to look at the other inequities of care that we see, what would be a starting list for you in terms of what are the opportunities?
Well, I do think they need to be community driven. We as a nonprofit health system, in our community health needs assessment, make that a priority to be sure that we understand the needs of the community, and that they're involved in the prioritization process. that again is going to vary by hospital and community, but you've got to have those relationships with communities. They need to be mutually beneficial, and I think that's one of the mistakes that I've seen many times, is that we're not really seeing the full value of community partners, but we're also not finding out what that give get is. What do they need from us, as opposed to what do we think we want to give to them.
Right. It's so interesting for us that we have all of these misconceptions about what we think the community needs and all of these other things. And I'd say we're wrong at least 50% of the time. And
At least, yes.
right. Yeah, that's probably being very, very generous, right? Um, but I think, Andy, on a positive note, the pandemic has been hard. It's the cracks in the system that we've seen. But we've also seen a kind of an amazing commitment in the field to improve health, and I think for the first time, I think as doctors, nurses, and health systems, we're getting the support of the public more so than a lot of other institutions. The question is, how do we seize the moment, so to say, and kind of move forward? And your tools and approaches at Vanderbilt and how you've done it and how you've addressed it and are really, really exciting. And what are the ways that, how do we, the biggest problem that we've had in healthcare is how do we spread those things? Because, I kind of look, as we've looked during the pandemic, you see these bright spots, and particularly being at the AHA, I'm able to see those. And you say, well, how do we bring all of those together? How do, obviously, efforts like this are helpful, but I think it's really important. How do we spread them? What are better ways that we could do that?
Well, I do think that, this pandemic has really made it clear that we're more connected than we'd like to at times, acknowledge. And that even when we're in the same markets, that we might be competing for some things, but things like health inequities are so big of a problem and so complex that we have to work together, and that, sharing how we do things and how we've actually made impact is not going to make us any less competitive. It actually is going to improve the lives of our community, and that's something that we should work towards. So I'm hoping that we'll see more opportunities to actually share the details. How do we set up this dashboard? Happy to provide those details and specifics, because there's no reason that we shouldn't all have a dashboard and be disaggregating data and using it to address inequities.
Well, that's fantastic. And I think we're going to take you up on that. And, Dr. Wilkins, on behalf of the American Hospital Association at Firefield, thank you for this great discussion. You and I, we could probably go on for another hour. And I know how busy you are. And, these insights make such a difference for us as we kind of move the field forward. So thanks for taking the time to listen. And, I just will put in a pitch. We're going to have a program on March 16th and 8th through the 18th through the AHA on advancing health equity. So we gotta strike while it's hot. I think we need to keep this issue front and center. And it's folks like you that are leading the country and helping us all. So we appreciate the time that you've spent with us. And thank you so much for being with us.
My pleasure. Thanks for having me.